Now we move on, and the next speaker is Dr. Vishal Agrawal, who is a prolific surgeon from Jaipur. So he'll be speaking on pediatric retina.
Thank you, ASRS, for giving me this talk. And I'll be speaking on vitrectomy in pediatric retinal detachments. As we all know, pediatric RDs account for less than 10% of all cases, and these are most related to trauma, syndromes, and congenital anomalies, unlike adult rhegmatogenous detachments. And traditionally, and even now, scleral buckling is the gold standard, and I would also prefer buckling as the first line management in all pediatric RDs. But there are many cases with varied anatomy and very late presentation, especially in children, and altered vitreoretinal adhesions. Deem many of such cases unsuitable for scleral buckling. So I'll be in the next course of 10 minutes talking about vitrectomy in detachments other than ROP, of course, because that's a different presentation altogether. So evaluation is very important. Systemic workup, evaluation under anesthesia and other screening is very important. These detachments are associated with familial conditions, so sibling screening, FFA and prophylactic lasers, especially in conditions like FEVR, is very important. And of course, a thorough preoperative counseling explaining all the risk and benefit to the parents has to be done. So coming to the surgical part, so there are many points to be considered. A thorough planning has to be done, whether you want to or not to want to put an encerclage. I always routinely put an encerclage in pediatric detachments, unlike in adult RDs where I do not. Lens management, of course, not a cosmetic surgery. If the lens is coming in between, you have to do a lensectomy. PVD induction is a major hindrance, and you should have a set technique to induce the hyaloid from the retina using of dye. Sometimes these cases require the large retinectomy, ILM peeling, and the choice of tamponade. So coming to the first part, that is PVD induction. So for the past many years, we have been using a simple and a very reproducible technique. We do a core vitrectomy and stain the vitreous with the triamcinolone acetonide and put a small amount of PFCl bubble at the posterior pole. And with the end gripping forceps, we try to make a hole in that hyaloid, which is very easy. It's just like peeling a membrane. And once that well or small hole is made, you just enlarge it a little bit and put more PFCl in that, and it generally atraumatically cleaves that hyaloid from the retina and till the equator, inducing the PVD. And from that point onwards, you can do it with the cutter. And there are many benefits, very atraumatic to the retina. And like in this case, there was a small bleed, and it automatically gets tamponated by the PFCl overlying it. So this works almost in every case of pediatric detachments. This is a wide-angle view of the same technique. You can use the forceps, or you can use a blunt dissector like the light pipe. And once you have made an adequate hole, you just have to sweep the other part, the other direction with the light pipe, like I'm doing here, gently, and the whole bubble goes inside. You refill it with PFCl, and you induce the PVD till the equator, and it works well. Coming to the common cases associated with pediatric detachments, of course, traumatic is the most common, and dialysis, of course, the first choice again is scleral buckling, but there are some cases where there is old dialysis, large dialysis with everted edges where scleral buckling will not work, although you have to augment the encerclage, it with the encerclage. Thorough base dissection and freshening up the edges of the dialysis is what usually works here, and there can be no compromise in the time you give to the peripheral dissection in these cases. So one thing I would like to point here is these are anterior pathologies, and you have to be very careful. Like in this case, the cannula was kinked, and all the fluid was going through the large dialysis into the subretinal space, and there was practically no place to work on. And we realized it in due course, and we did not proceed with the surgery and shifted the cannula to the inferior nasal quadrant, and now you can see. And this is a quite old video, and the retina then settled. So you have to keep in mind about the fluid direction in cases you're operating the anterior pathology. Stickler syndrome. So we were working in a tertiary care center where a lot of referral Stickler syndromes were coming with GRTs. And the point here is it's optically empty vitreous. So a fresh GRT will also curl and adhere to the other part of the retina, and you just cannot unroll the retina with the PFCl here. And if you forcefully do it, it will go into the subretinal space. So this is only a 7-day GRT and seemingly fresh-looking GRT. And you can see the rolled-up edges and the fibrosis, and it could not be unrolled with the PFCL. So you had to use the, the brush and the forceps to unroll it and trim the edges. So you can either do a oil exchange or a air exchange and then laser. So, and the other thing here in Stickler syndrome is that you have to examine the periphery very well, and even if there is a detachment, you have repaired that, and the other area is a retina on area. If you see an indent, in many cases you'll find these seemingly sieve-like lattices, and if you do vitrectomy over, they'll just open up. So you have to keep in mind to do a thorough 360-degree base indentation and check for all these, lesions in the periphery, in the attached retina also. The third video of the Stickler is because there are radial lattices and you can get GRTs with the radial rips here. And the whole surgery is as you do a routine GRT, but the important thing here to remember is that the radial rips are very prone. These areas are very prone where the PFCL might go into subretinal space. You have to be very careful in these areas especially, otherwise it's not much of a different surgery than the other GRT surgeries. Coloboma RDs are difficult surgeries because the attachment to the hyaloid at the edge of the retina and the coloboma is very difficult to detach. So there are multiple techniques you can do, to achieve that. Again, we use the same technique as I described in the first few slides, making a hyaloid cleavage plane and injecting PFCL. And this works very well in these cases also. As you can see, the whole hyaloid layer has been detached, and you just need a gentle nudge from the cutter to detach it from the colobomatous area. Coming to FEVR cases, this was my first case of FEVR, which I did almost 10 years back, and I did not know the complexities of these, of these cases. And you can see this temporal fibrovascular area, and I thought I would, peel it, but that was a very, good learning lesson to me, because this is so adherent that if you try to peel it, you will create bleeding, you will create inadvertent iatrogenic breaks, and there is no point you can peel it. The only thing you can do is to just shave it off. So after 6 or 7 years, this boy, 18-year-old male, developed RD in the second eye of his, and this was apparently very well lasered. And here, I had learned my lessons, so I did not try to peel much the temporal fibrovascular area, just peeled the interior and the posterior edges. But there are anomalous additions to the posterior pole also. As you can see, as I was inducing gently the PVD, iatrogenic macular hole formed. So you have to be very gentle and very slow in these cases, because you don't know multiple attachments are there and they might create complications. You can see the laser barrage in this case, which I had done around 10 years back, and still there was a break which formed at the edge of the CRA and caused a RD. For the macular hole, of course, you do the routine thing. We did the routine inverted ILM peeling, which I do under PFCL, and the patient did fine in the post-op period. A thorough base indentation and a thorough laser anterior and posterior to that fibrovascular band which you can see. So these were relatively fresh RDs secondary to FEVR. This was, you can see as it looks, a very old detachment with demarcation lines and pigment dispersion. And these are difficult cases, and you don't get that PVD hyaloid thing I was talking about in the PFCL. The only way here is you have to be patient and give time and continuously, grasping and re-grasping the hyaloid layer and inducing a PVD. And there is no other alternative to that. There is no technique defined in the book to do a seamless PVD induction in these cases. But it will go off if you do keep on trying and keeping in mind not to injure the underlying retina. And the patient did well, and this is the post-op photograph under the oil, 3 weeks post-op. This was a 10-year-old boy, had undergone a scleral buckling, was doing fine for 1 year, again developed RD, oculocutaneous albinism, and we could not find the primary break. So this is what we did. We created a retinotomy, injected PFCL at the posterior pole, and injected some subretinal trypan blue. And with the Brownian movement, you can see that it's coming out through the break. Because it is so less contrast, it's impossible to find the causative break in some cases. And we could find here, and then, laser barrage and cry out that break. The patient did fine in the post-op period. No matter how careful you are and meticulous you are, there will be redetachments in these cases, and you have to go inside early. And in these cases, I have found that the trypan blue dye is very helpful in delineating all the epiretinal membranes and the remnant fibrotic layers. Here you can see the whole membrane, which had led to the PVR and redetachment, comes out in one go with end gripping forceps. And of course, after you peel that, you of course have to do ILM peeling in this case to reduce the incidence of macular pucker. So as I was saying in the initial slide, these are not cosmetic surgeries, and if there is a lot of anterior PVR, you have to sacrifice the lens. You of course avoid in most of the cases, but not at the cost of settling the retina. So here we peeled the retina, removed all the membranes, but could not settle and relieve the traction. So a relaxing retinotomy was done, and the thing about relaxing retinotomy is that it cannot be a small RR, it cannot be a modest RR. You have to do a large RR to settle the retina and adequately relieve the traction. So the last cases, of course, some traumatic RDs are associated with the macular hole, and this one was a very large macular hole. And this is the technique we usually do. We peel the ILM in a broad-based fashion and under the PFCL, and you see that we are fashioning the flaps very near the arcade and turning them over the hole. You don't need to stuff them into the hole, but on the PFCL, they stick well inside the hole. The patient did fine, anatomically at least, in the post-op period. So to conclude, vitrectomy in children, because for RD, is challenging because of the unique anatomy, and if performed meticulously, taking care of the anatomy, can yield excellent results. Of course, it's not a perfect science, and there is no standardized treatment. Every case has to be managed in a customized way. And the final thing is visual gain remains suboptimal in many of these cases because of the late presentation and possible irreversible photoreceptor damage, and that has to be conveyed to the parents. Thank you so much.